If your child isn't talking yet, or is talking much less than other children their age, you've probably found yourself searching for answers. And if you're a therapist working with young children who have language delays, you know that choosing the right approach matters enormously. In this video, we're going to explore 5 of the most widely used speech-language therapy approaches for late-talking toddlers and children with speech or language delays. More than just describing what therapists do, we'll look at why they do it, the theories of language development that shape each approach. The key insight here is how a therapist understands how children learn language directly determines the kind of treatment they provide. 2 children with similar profiles might receive very different therapy, and understanding the theory behind each approach can help parents ask better questions and help clinicians make more informed decisions. Let's get started. One of the most widely used and well-researched approaches for late talkers is parent-implemented language intervention. As the name suggests, this model puts parents at the center of therapy. Rather than working with a child alone in a therapy room, a speech-language pathologist coaches parents to support language development during everyday routines: play, mealtimes, bath time, book reading. The idea is that therapy happens all day long, not just during a weekly session. Parents learn strategies such as following the child's lead during play, letting the child choose the activity, and joining in modeling simple language at just above the child's current level. Expanding what the child says by adding a word or idea, responding to gestures and sounds as meaningful communication, creating natural opportunities for the child to communicate. An example would be, child sees a ball and says, "Ba." Parent responds to what the child says, "Ball, big ball, throw the ball." Programs developed by the Hanen Center are among the most widely used frameworks for this approach. The theory behind this approach is grounded in social interactionist theory, the idea that children learn language primarily through meaningful social engagement with the people around them. Researchers like Jerome Bruner, Michael Tomasello, and Catherine Snow helped establish this view. Their work showed that language doesn't develop in isolation. It grows out of shared attention, back-and-forth interaction, and the drive to connect with other people. From this perspective, the most powerful language learning environment isn't a therapy room, it's the child's own home, with the people who love them most. Enhanced milieu teaching, or EMT, is another well-supported approach for late-talking children. Like parent-implemented intervention, it takes place during play and natural interaction, but it adds a layer of structured teaching embedded within those interactions. The therapist, or a trained caregiver, deliberately sets up the environment to create opportunities for the child to communicate. For example, a favorite toy is placed just out of reach, so the child has a reason to ask for it. When the child attempts to communicate, the therapist responds by using strategies such as modeling language, or demonstrating to the child what words to use for desired communication outcome. Prompting communication, gently encouraging a response, expanding the child's words, adding more language to what they said, reinforcing communication attempts, making sure the child gets what they were asking for. Example: child says, "Ka." Therapist responds to the child by saying, "Car, you want the red car, here's the car." The theory behind EMT sits at the intersection of 2 theoretical traditions: behavioral learning theory and developmental interaction approaches. The behavioral roots trace back to B.F. Skinner, who demonstrated that behaviors, including communication, increase when they are consistently reinforced. If a child asks for something and gets it, they're more likely to ask again. Researchers Ann Kaiser and Terry Hancock refined and expanded EMT, weaving in developmental principles to ensure the approach feels natural and child-friendly rather than mechanical. The result is a therapy that teaches communication while preserving the warmth and spontaneity of real interaction. Another therapy approach is focused stimulation. In this approach, the therapist or parent repeatedly models specific words or grammatical structures during play, without requiring the child to imitate or produce those words right away. The child simply hears the target language many times in meaningful and varied contexts. Over time, through repeated exposure, the words or structures become part of the child's own language. An example of focused stimulation is when child is attempting to open something, and during these attempts to open, the parent or therapist may model language to describe what the child wants to do. Let's open the box. Open the door. Can you open it? I'm going to open the lid. There's no pressure on the child to respond. The goal is rich, repeated input, and then waiting for the language to emerge naturally. The theory behind focused stimulation draws on usage-based and linguistic theories of language acquisition, associated with researchers like Brian McWhinney, Elizabeth Bates, and Michael Tomasello. These theories propose that children learn language by detecting patterns in what they hear. The more often a child hears a word used in meaningful ways, the more likely that word is to take root. This stands in contrast to approaches that emphasize direct teaching or imitation. Here, the mechanism of learning is input, hearing language in context, repeatedly and naturally. While the previous three approaches focus on getting children to talk more, phonological approaches address a different challenge: children who are speaking, but whose speech is difficult to understand. These therapies help children learn how the sound system of their language works. Rather than drilling individual sounds in isolation, they target patterns, the systematic rules that govern which sounds appear where and how they contrast with each other. Common phonological techniques include minimal pair therapy, practicing pairs of words that differ by just one sound, e.g., cat versus bat. Phonological contrast therapy, helping the child hear and produce meaningful sound distinctions. The cycles approach, rotating through different phonological patterns over time. An example of a phonological approach is when a child says tar instead of car, an exercise to improve the child's understanding of the underlying phonological rule is practicing the contrast of the dai and ka-bai sounds in a playful, structured activity. The theories behind phonological approaches are grounded in linguistic theories of phonology, the branch of linguistics that studies sound systems. Researchers like David Ingram, Barbara Hodson, Judith Geroot, and Barbara Dodd contributed foundational work in this area. Their research revealed that many children's speech errors aren't random. They reflect underlying patterns in how the child has organized the sound system of their language. Within this framework, the goal of therapy isn't just to correct individual sounds. It's to reorganize the child's phonological system, to help them understand and use the contrasts that make speech meaningful. Our fifth category, Naturalistic Developmental Behavioral Interventions, or NDBIs, brings together developmental and behavioral principles in a unified framework. These approaches are often used with children who have language delays alongside autism or significant communication challenges. Like the other play-based approaches we've discussed, NDBIs occur during natural interactions rather than structured drills. But they also incorporate the explicit teaching strategies found in behavioral approaches. Key targets of naturalistic developmental behavioral interventions include joint attention, looking at and sharing interest in the same thing as another person's shared engagement, participating together in an activity communication attempts of any kind, gestures, sounds, words. Early language modeling embedded within play. The theory behind NDBIs reflect a synthesis of developmental psychology and behavioral learning theory. Two influential researchers in this area are Geraldine Dawson and Sally Rogers, whose work on early autism intervention helped establish the evidence base for these approaches. The core insight is that early communication doesn't develop through social interaction alone or through structured teaching alone. For some children, both are needed. The warmth and responsiveness of natural interaction, combined with the clarity and consistency of structured learning. To put the three theoretical perspectives together, we need to step back and look across all five approaches. When stepping back, we can see that most traditional speech-language therapy for late-talking toddlers draws from three major theoretical traditions: social interactionist theory, behavioral learning theory, and linguistic theories of phonology and grammar. From a social interactionist theory, language develops through communication and connection with caregivers. Therapy should be embedded in real, warm, meaningful interaction. The approaches from this perspective are parent-implemented intervention and focused stimulation. Using behavioral learning theory, language behaviors increase when they are reinforced through consistent, responsive interaction. Structure and intentional teaching matter. Approaches from the behavioral learning theory are enhanced milieu teaching and NDBIs. Linguistic theories of phonology and grammar assume that children must acquire the structural rules of their language, its sound patterns, word forms, and grammatical structures. Therapy targets these systems directly. Phonological approaches to speech and language therapy make use of linguistic theories. In practice, most skilled clinicians draw on more than one tradition. A therapist might use parent coaching rooted in social interactionist theory, while also using structured prompting from behavioral theory. The theories aren't competing, they're complementary lenses. While all the approaches discussed here are well-researched and effective for many children, what happens when these approaches fail? Every speech and language pathologist has experienced working with a young child where they implemented many of the approaches and nothing seemed to help. When traditional approaches plateau or fail to produce meaningful change, it's worth asking a deeper question. Are we working from the right theory? Traditional approaches to language development mainly focus on input in mostly natural environments, with little, if any, focus on a child's speech production skills. In many late-talking children, the main parental concern is their child's inability to talk. If there are no social, behavioral, or linguistic problems, traditional methods of intervention are more likely to fail. Until recently, research on language development has focused on production milestones and linguistic skill development, hence the focus on these factors in early language therapy. More recently, research into the development of production skills has emerged for the onset of speech production skills. Unfortunately, the understanding and use of this research has been slow to enter the field. At ExpressIt, this is the focus of our assessment and treatment based on the research of Dr. Jen's dissertation and published research. All of our therapists are trained in early language development and understand how to differentiate between traditional speech and language delays and specific speech production problems in the developing child. For the clinicians here at ExpressIt, the approach we choose reflects assumptions about how we believe children learn language. We happily share our assumptions and continue to learn and grow as therapists. We are always open to revising our understanding of speech and language development. We take pride in providing thoughtful, evidence-based practice that focuses on specific speech and language problems for the most effective outcomes. Follow to learn more about our therapy approaches and the theories and research that support what we do.